Good morning, students. Today's class we will see about the coagulation failure in pregnancy. Coagulation and fibrinolytic system during pregnancy. Placental separation during the third stage of labor represents a major hemostatic challenge to the mother. Physiological adaptation occurred during pregnancy to help the mother to meet this hemostatic challenge. Together, the change in coagulation and fibrinolysis in pregnancy represent a hypercoagulable stage. Plasma fibrinogen concentrations rise during pregnancy by about 50%. This means that double the amount of fibrinogen is available to a pregnant woman at delivery. Concentration to other clotting factors also rise, especially prothrombin factors 5, 7, 8, 9, 10, and 12. Notable exceptions are the factor 11 and 13, whose concentrations fall during pregnancy. Despite the increased potential to form thrombin in pregnancy, there is no compensatory rise in antithrombin 3. Platelet count shows little, if any, change. And the plasminogen levels rise in a tandem with the rise of fibrinogen. Antiplasmins also rise so that the capacity to generate plasmin may be reduced in pregnancy. Following delivery, major changes occur in the coagulation fibrinolytic system. Rise in plasminogen activator activity, which return to a non-pregnant range within 30 minutes of delivery. Fibrinogen level and platelets count rise during early puerperium. Antithrombin activity increases. Following the initial phase of increased clotting factors in the puerperium, the coagulation fibrinolytic system gradually revert to normal within 6 weeks after delivery. The coagulation changes which occurred during pregnancy, bleeding during labor is dealt with effectively by increased production of coagulation factors during pregnancy, increased blood volume, and myometrial contractions. Classification of coagulation disorders during pregnancy are divided into congenital coagulopathies and acquired coagulopathies. Among the congenital coagulopathies, Willebrand disease, hemophilia A and B, and thrombin deficiency. Acquired coagulopathies include PIH, placental abruption, retained dead fetus, amniotic fluid embolus, liver disease, anticoagulants like aspirin and heparin. Platelet abnormalities. First is the quantitative, it is not enough platelets, gestational thrombocytopenia or idiopathic or immunological thrombocytopenic purpura, HELP syndrome, DIC. Second is the qualitative disorders, that is poor platelet function. Third is disorders predisposing to thrombosis like antiphospholipid syndrome. Screening tests for hemostasis include tests for the primary hemostasis like bleeding time, PFA system, platelet count, blood smear, secondary hemostasis like clotting system, prothrombin time, activator partial thromboplastin time. Bleeding time provides an assessment of a platelet count and the function. Normal values between 2 to 8 minutes. Platelet count it is normal between 1,50,000 to 4 lakhs. If it is below 1 lakh, it's thrombocytopenia. 5,000 to 50,000 to 1 lakh means mild thrombocytopenia. Below 50,000 includes severe thrombocytopenia. INR, otherwise known as International Normalized Ratio, established by WHO and International Committee on Thrombosis and Hemostasis for reporting the results of prothrombin test. All PT results standardized by this calculation. Activated partial thromboplastin time. It measures effectiveness of the intrinsic pathway and common pathway. Normal values between 25 to 40 seconds. APTT prolongs the intrinsic path deficiencies like inherited or acquired, consumptions like DIC, and PIVK factors in coumarin therapy. Specific inhibitors against factor 12, 11, 8, 9. Lupus anticoagulant and non-fractionated heparin therapy. Thrombin time, the time for thrombin to convert to fibrinogen to fibrin. It measures the fibrinolytic pathway. Then the thrombin time prolongs. It shows hypofibrinogemia, dysfibrinogemia, non-fractionated heparin, fibrogen or fibrin degradation protect chronic liver disease. Specific tests like platelet aggregation test, flow cytometry, test for platelet secretions, clot retraction test, platelet procoagulant activity. Tests for coagulation phase include quantitative estimation of fibrinogen, coagulation factor assays, and latex agglutination tests for fibrinolysis. First, it comes the ward build and the symptomatic patients usually present with evidence of a platelet defect, considered in a woman with a bleeding suggestive of a chronic disorder of coagulation. During normal pregnancy, maternal levels of both factor VIII as well as ward build and factor antigen increase substantially. Because of this, pregnant women with von Willebrand disease often develop normal levels of factor VIII coagulant activity as well as what will brand factor antigen, although bleeding time still may be prolonged. If the factor VIII activity is very low or if there is a bleeding, treatment is recommended. Desmopressin by infusion may transiently increase factor VIII and Ward Willebrand factor levels. Pregnancy outcomes in women with Ward Willebrand disease generally good, but postpartum hemorrhage encountered up to 50% of cases. Second is hemophilia, that injury occurs in normal cases along with other substance clotting factor 7 causes strong platelet plug to form, but in hemophilia, lack of clotting factor 8 causes a weak platelet plug, so incomplete or delayed fibrin cord allows bleeding to continue. Patients with hemophilia A or B, because of prior treatment with factor 8 or 9, may develop antibodies that directed against factor 8 or 9 and may lead to the life-threatening hemorrhage. Rarely, in puerperium, one may result as a severe, protracted, repetitive hemorrhage from the reproductive tract starting a week or so after apparently uncomplicated delivery. The activated partial thromboplastin time is markedly prolonged. Treatment has included multiple transfusions of whole blood and plasma and clotting factors. Hypoprothrombinemia. This disorder is a deficiency of prothrombin or factor II, a glycoprotein formed and stored in the liver. Some patients may show no symptoms and others will suffer from severe hemorrhage. Patients may experience easy bruising, profuse nosebleed, postpartum hemorrhage, excessively prolonged or heavy menstrual bleeding, and post-surgical hemorrhage. Hypoprothrombinemia may also acquire rather than inherited and usually result in the vitamin K deficiency caused by liver disease, newborn hemorrhagic disease, or a number of other factors. Thrombocytopenia is reduction of the platelets below 150,000. The causes include incidental thrombocytopenia of pregnancy, increased consumption, idiopathic autoimmune thrombocytopenia, SLE or antiplatelet syndrome, activated clotting mechanism in case of preeclampsia, HERPS syndrome or DIC, thrombotic thrombocytopenic purpura, decreased platelet functions like say in case of sepsis or HIV, malignant marrow infiltration. Idiopathic thrombocytopenic purpura. In idiopathic, it is a common autoimmune disorder in which patients form antiplatelet autoantibodies against platelet-specific antigen. Major bleeding rarely seen unless platelet count is less. Maternal antibodies may cross the placenta and affect the fetus, causing neonatal thrombocytopenia. 4 to 10% of neonates are at risk of having severe thrombocytopenia at birth or at the first week of life. Features suggestive of thrombocytopenia: platelet count is less than 1 lakh, increased number of megakaryocytes, increased platelet volume. Thrombocytopenic coagulopathies treatment include: first is the conservative management. Among that, the corticosteroid. If the platelet count is less than 20,000 before the onset of labor or less than 50,000 at the time of delivery. High dose of IV immunoglobulin produces increase in the platelet count. Significant hemorrhage in case of immediate postpartum period, we have to go for a platelet transfusion. Theoretical risk of intracranial hemorrhage in the thrombocytopenic fetus has not shown to be reduced by cesarean section. Therefore, cesarean section should be performed for obstetric reasons. HELPS syndrome. The acronym HELPS, coined by Westin in 1982 to describe a syndrome consisting of hemolysis, elevated liver enzyme, and low platelet. It is a syndrome that characterized by hepatic endothelial disruption followed by platelet activation, aggravation, and consumption, ultimately resulting in ischemia and hepatocyte death. The findings of multisystem disease attributed by abnormal vascular tone, vasospasm, and coagulation defect. the classical histological lesion in liver, hemolysis, and thrombocytopenia. It occurs in 0.2 to 0.6% of all pregnancy. It's a multi-center study conducted in a woman with HELP syndrome. 40% had adverse outcomes in the subcapsular liver hematoma, eclampsia, placental abruption, acute kidney and pulmonary edema, stroke, coagulopathy, acute respiratory distress syndrome, and sepsis. Laboratory findings: low platelet, elevated liver enzyme, hemolysis, leukocytosis, coagulation factors, serum uric acid raise, and hypoglycemia. Peripheral smear shows pyrocytosis, cyrocytes, and reticulocytosis, anisocytosis, triangular cells, helmet cells, Burr cells, and polychromosomia. Management: immediate delivery at or not more than 34 weeks of gestation, delivery within 48 hours after evaluation and stabilization of maternal clinical steroid treatment, expectant conservative management before 27 weeks of gestation. Role of transfusion: we can go for a platelet transfusion, packed cell volume, or a fresh frozen plasma. DIC. It is an acquired syndrome characterized by systemic intravascular coagulation. Coagulation always by initial event. DIC is most common maternal complication, reported frequency varying from 4 to 38%. We have seen detailed in DIC in one of the another video. So just going to the some essential factors of DIC. So conditions also with release of tissue, conditions also with endothelial damage, conditions have non-specific indirect action, gram-negative septicemia, saline abortion. Clinical manifestation of DIC include means it is divided into two: those of the underlying cause and those due to the complication of DIC. Hemorrhagic manifestation include ecchymosis, petechiae, bleeding from the gum, hematuria, GIT bleeding, venipuncture oozing, intracranial or intracerebral hemorrhage. Thrombotic manifestations include neurologic with multifocal lesions, delirium, coma, dermatologic with focal ischemia and superficial gangrene, renal with cortical necrosis and uremia, GIT acute ulceration with bleeding, vascular occlusion causing pulmonary infarction or peripheral vascular gangrene. Lab result: markedly increased fibrin degradation products, fragmented RBCs and microspirocytes, the peripheral blood film, low fibrinogen factor, prolonged PT, PTT, and TT. Treatment: remove the underlying cause, replenish the depleted factors. The fresh frozen plasma provides source of most factors. Cryoprecipitate provide fibrinogen, platelet and blood support. Questions using of heparin. Thrombophilia. It is defined as a predisposition of thrombosis secondary to any persistent or identified hypercoagulable state. Although these disorders are collectively present in about 15% of population, they are responsible for about 50% of all thromboembolic events during pregnancy. DVT alone more common antepartum, whereas pulmonary embolism more common in the first 6 weeks of postpartum. It can be inherited or acquired. It should also be considered the patients who have recurrent pregnancy loss, unexplained IUFD or intrauterine fetal death, and early severe intrauterine dose restriction. Cause of thrombophilia. Inherited causes include antithrombin 3 deficiency. Antithrombin 3 is a naturally occurring anticoagulant. It inactivates the thrombin factors. This is an autosomal dominant condition. The clinical manifestation is thrombosis. The risk of thrombosis during pregnancy among antithrombin deficient women without personal or family history is 3 to 7%, and it is up to 11 to 40% with such history. It may be acquired deficiency in patients with DIC, nephrotic syndrome, liver disease, preeclampsia during oral contraceptive use, and using heparin therapy. Protein deficiency, it also autosomal dominant. This is next to thrombophilia. Protein S deficiency is also autosomal dominant. Factor V Levin mutation, prothrombin gene mutation. Acquired cause of thrombophilia is the most common is antiphospholipid syndrome. Antiphospholipid syndrome. The antibodies that directed against cardiolipins or against a phospholipid binding protein such as B2 glycoprotein. Women with moderate to high levels of these antibodies may have antiphospholipid syndrome, which is defined by a number of clinical features as thromboembolism or recurrent early trimester unexplained fetal death. It is found to be associated with 3 to 4% of early pregnancy loss. It is postulated that there may be interfere with the normal function of phospholipid or phospholipid binding proteins involved in coagulation regulation, including prothrombin, protein C, and exin 5, and tissue factor. Many of these antibodies are directed against beta-glycoprotein 1, which may itself function as a natural anticoagulant. In conclusion, blood coagulation is a major component for the hemostasis. Increased coagulation factors levels in pregnancy is meant to minimize the blood loss at the time of delivery. The hematostatic mechanism could fail, risking patient's life. Thrombocytopenic coagulation failure and DIC syndrome are the most commonly seen in obstetric practice. Congenital causes of coagulation failure are uncommon and usually already diagnosed prior to pregnancy. DIC syndrome is always secondary to an underlying pathology. If diagnosis of DIC is missed or appropriate action is delayed, it can cause serious maternal morbidity or even death. Platelet transfusion and coagulation factor replacement or fresh blood transfusions are mainstream of treatment besides other supportive therapy. Use of heparin is controversial. Hematologist opinion should be sought before it is used. Thank you. Thank you for listening.